So next we will have a bit of our sponsorship videos while we switch our speakers. Let's start a bit of advertisement. Yes. Thank you. Welcome back to first live webinar of the YAC groups. Next speakers, I would like to introduce Professor Aizura. Aizura is my long beloved friend, and she graduated from the University of Malaya, and then we studied together in Changkeng Memorial Hospitals, but she still further on study in Belgium as well. Right now, Actually, she's one of the founders of the YAC group as well, and right now she also as the vice president of the YAC members, YAC committees. Professor Aizura is very dedicated and no nonsense surgery. She is very strong and she very dedicated in teachings in Malaysia, and right now she would like to give us lectures on ureteric injuries. Let us welcome Professor Aizura to give her speech. Please, Aizura, thank you so much for coming.
Thank you, Willie, for that very very illustrious introduction. Can you see my slide? Can you see my slide?
Yes. Okay. Very good.
Well, I was trying to figure out how do I make it interesting, having not met any of you guys for the last 2 years or so, and looking at the topics. But I also thought that perhaps one area that we have never actually attempted or dealt with is actually talking about actual complications. So I wanted to go with a grand walk round this time to discuss about a very common and a very feared injury, which is a ureteric injury. And so today it will be titled a ureteric injury post-total laparoscopic hysterectomy. Okay, so the picture on the left is me now. The picture on the right is me back in the day when Willie called me to attend the first BMIS meeting. And you can see I wasn't fat, I was actually pregnant. And that little girl is now 8 years old. So that's how long I was in Charangkrung Pracara in those days. So thank you again, Virapol, for inviting me to come after all these years. So yes, we do go back a long way. All right, now, just to remember, I want you to remember this, as I mention it now, that within the Hippocratic Oath, we know that we say, to hold my teacher in this art equal to my own parents, to consider his family as my own brothers, and to teach them this art if they want to learn it without fee or indenture, to impart precept, oral instruction, and all other instruction to my own sons, the sons of my teacher, and to indentured pupils who have taken the healer's oath, but to nobody else. And I think Yak agrees with this oath through and through, and it is inevitably a prayer that we all say in our own way. All right, let's get on with the case presentation. Now, Madam X is a 38-year-old lady, para 2, both spontaneous vaginal deliveries, with her last childbirth being 11 years ago. She weighs 55 kilograms and she is 159 centimeters with a BMI of 22.4. Now, she only has migraine, which is on treatment, and a previous appendicectomy back in 2007. Back in 2018, her presentation was actually an abnormal uterine bleeding. Now, clinical assessment was very insignificant. When we did a PIPEL, an endometrial biopsy, it only showed a secretory endometrium. And at that point, she was given medical treatment, being young, with cyclical tranexamic acid only to control her bleeding. Subsequently, in 2019, it was found that it only responded partially, and she developed anemia, having a hemoglobin of 8 grams per deciliters. So she received oral hematinics, but no blood transfusion was required at that point. She had persistent symptoms in 2020. An office hysteroscopy revealed an endometrial polyp, and a pap smear which was unsatisfactory, atypical squamous cells, and a colposcopy which showed that there were metaplastic changes. Now, considering at this point that she had 2 pathologies coexisting with the abnormal uterine bleeding and the, a very disturbing cervical findings, she was suggested for Mirena, but when she was given the Mirena, she was not happy because it gave her persistent discharge. Hormonal treatment, she wasn't happy too because she says she has migraine. And so a surgical intervention was suggested to control the abnormal uterine bleeding as well as the abnormal pap smear. Patient then opted for surgery and planned for a total laparoscopic hysterectomy. Now, within the intraoperative procedure, which was very typical, she underwent a total laparoscopic hysterectomy under general anesthesia. Patient was in Lloyd-Davis position with the CBD in situ, and we used a direct vision to enter using the umbilical ports. Additional 3 ports were put at the left lumbar, left iliac fossa, and the right iliac fossa. Our intraoperative findings were that of a 12-week size uterus. Bilateral ovaries were normal, but a thickened uterosacral ligaments. Now, towards the dissection of the cardinal ligaments, bilateral ureters were clearly identified. We proceeded with thermal energy to transect the cardinal and the uterosacral ligaments and colpotomy, and the surgery was completed in its usual manner. Now, what happened was that after the surgery, the Radivac drain, which was in situ, was removed when the drain was less than 50 mils. She had an inward observation for about 48 hours, and she was pain-free, ambulating well, passed flatus, and was passing urine, and she was discharged post-op day 2 with oral antibiotics and analgesia. This is then what happened. On post-op day 8, she came to emergency department with complaint of suprapubic pain, dysuria, and an incomplete voiding for a day. Now, clinically, she was afebrile, hemodynamically stable, Abdominal examination was not distended, there was no guarding, there was mild tenderness, but nothing other than the significant, and there was no fluid collection on transabdominal scan. The total white count was 15, there was no hemoglobin reduction, and the renal profile was not deranged. And there was also no evidence of urinary infection at that point. But nevertheless, we admitted her and treated her on antibiotics. In day 2, when she was admitted, she had abdominal pain. We did an ultrasound and it showed a mild dilatation of the left renal calyx. So worried about a delayed ureteric injury, we asked for a CT urogram IVU, and that showed that there was active contrast leaking from the left distal ureter draining into a collection which was actually rather small, 2 by 4 by 3 centimeters of a urinoma. So at that point, the diagnosis was a left distal ureteric injury. So she was then referred to the urologist and a retrograde pyelogram was done, and insertion of the left ureteric JJ stent was done. And she was then further observed for another 2 days and discharged with the CBD going back home. Now, the sequelae of the ureteric injury, she was subsequently a bit unhappy that she had to have a CBD with her. She wanted it removed. So we had that removed. The histopathology came back with an adenomatoid tumor, and it was a fibroid with an ectocervix of coilocytosis and of a CIN1. 1 week later, she developed fever, admitted for urosepsis, and she was found to have an infection, but a repeat CTU shows that the JJ stent was in situ, there was no hydronephrosis, but there was a small left ureterovaginal fistula. Now, subsequently, she is now comfortable and awaiting for a repeat CT IVU whilst undergoing the antibiotic treatment. Now, the reason why we are actually discussing this case is because there are a lot of talks on techniques and a lot of thoughts on updates, but nobody actually discusses the issue of complications. And I think instead of hiding certain complications, we might as well talk about it and discuss it across the board to see whether other people are also having similar problems. And although most of us surgeons would be quite anal in making sure that we see things well, these are the kind of cases which have been missed in a what appears to be a simple hysterectomy. So let's go through it. If you can see, that would be the uterus. And I am showing the ovary. As you can see, the uterus, if you can see a little bit, that it was actually maybe what? Was that perforated by the manipulator? Probably. Okay. So you can see clearly here, the ureter is delineated there. We can see it is identified, and there is a little bit of a stricture here. Okay. The infundibulopelvic ligaments were cut away. The ureter in view, which has good peristalsis movement and always visualized clearly. Okay. And they went on to do the UV fold. Now, here we were delineating the uterine artery away from the ureter. And you can see the uterine artery there as there is a sign of a blood flow. Okay. So it is quite a distance in actual fact. Uterine artery is there. And it is being cauterized. Okay. Authorization continues. And we haven't cut anything away yet. So for fear that the ureter might be near, but we have again identified where it is, the prodding and the probing that you see is when they are trying to identify the colpotomy cup. You will see it in a bit. Okay. So the ureter is in view, but we do not need to go there. This is away. The uterine is away. And looking for the colpotomy cup. All right. And there. So it is actually quite a distance away. There is the colpotomizer. So in actual fact, that is the area that needs to be dissected only, right? Okay. So the area is dissected. Okay, so we're looking and there are no signs of ureter which is kinked upwards or anywhere. That is the whole cup involved. Okay. So yes, it is deemed away. And so when the diathermy was determined, it was away from the ureter. That is the uterine artery. Okay. Okay. So you can see that it was applied actually further away from the ureter. Nevertheless, I think there was some amount of spark or a thermal injury that would have caused the problem because it is a small urinoma. Right. Dissection was done. And identifying the colpotomy cup from the posterior end. So as we came out of the surgery, it didn't feel like there was any complications that were going to happen or was about to happen. But nevertheless, there is a learning curve here. And I am not embarrassed to say that there is a learning curve for everyone and we should talk about it. Number one, when we understand the ureteric injury during the laparoscopic surgery, how do we reduce this incidence? How is the detection can be happen? How can we make a detection intraoperatively? And of course, we need to recognize a delayed ureteric injury, which in my opinion, this is probably due to a thermal injury unless anybody else has, we will open it to the floor. We will open it to the floor for the discussion after this. Right, So we know that the incidence of ureteral injury has been documented during gynecologic laparoscopy ranges from 1% to 2%. And even if we can promise the stars and the moons, there is still that small risk even in the experts of hands. There is a higher risk of ureteral injury with laparoscopic approach to hysterectomy when compared with abdominal and vaginal approach. We know that, and it has been written time and again as well. And the ureteral injury can occur due to transection, obstruction, fistula formation, and necrosis from thermal injury. So with regards to preoperative risk stratification, she did not have a malignancy, okay? Gynecologic surgery for malignancy may have a higher baseline risk of ureteral injury, so that did not happen to her. Presence of anatomic distortion, such as a previous pelvic surgery, endometriosis, okay? She has pelvic adhesions and enlarged uteri, adnexal masses, cervical or broad ligament fibroids. That is probably one risk factor that she has. And an intraoperative hemorrhage is associated with ureteral injury when the visualization of the operative field is obscured. That was not a problem that we had to face. So, came to the discussion whether we need to stent. A lot of people will say, if we are worried, why don't we stent? Unfortunately, in such cases, we did not think that there was any problem. So I would also like to open it to the floor to discuss whether people believe in stenting pre-operatively. Stenting, we know it can be associated with discomfort, irritated bladder symptoms, fever and flank pain. And during the procedure, the ability and the tactile sensation to palpate the ureteral stents in order to confirm location is diminished. So what we can do is we can see, and sometimes when we see, we tend to grab, and could we have caused an injury by trying to delineate where the ureter is, which would further then stop the blood supply or reduce the blood supply to the ureter. No documentation of any differences between the ureteral injury rates during major gynecologic surgery with the use of prophylactic stenting. And prophylactic stenting, there is a paper which says that if you place a prophylactic stenting, maybe cost saving in benign or radical hysterectomy, in which the injury rate is quoted as 3.2%. So here I just feature you a novel video of a lighted stent to show whether should we even go to this extent where there is light source within the stent so as for you not to dissect and cut it away. I have seen some practices where they have attempted using a blinking sort of light, which creates a whole lot of confusion for the surgeons because now it looks like Christmas is coming. So this is one area where you can see where you are about to colpotomize is probably a good 2-3 centimeters away from the ureter. So for new beginners, in actuality, it is always good to push away the uterus as high as possible to try and move the ureter away from the corpus of the uterus so that you don't get into trouble. So you can see that it's about this distance that we are playing with, which is not much, So again, the common sites will be, of course, the infundibulopelvic ligament area, along the lateral border of the uterosacral ligament, that's also another area. Of course, the most common site, and like in this patient, is within the cardinal ligament area or near the anterior vaginal wall. So some will talk about sufficient skeletonization of the uterine vasculature, which is probably what we should have done despite the stricture that was available. Maybe we should have skeletonized the whole area to completely release the ureter away from the area, even though we thought that the area was already quite far apart. And if you can maintain a cranial deviation with a firm upward pressure, move the uterus upward pressure so as to push it away so that the ureters will be lateralized before you incise the uterine vessel. And this upward traction works especially as a uterine manipulator as well, to the left and to the right. It acts as an extra assistant. And you take the ascending uterine vessels at the level of the internal cervical os to create a pedicle that lateralizes the uterine vessels away from the colpotomy cup. Intra-op detection, IV dye injection or retrograde bladder urethral dye injection can be used with indigo carmine or methylene blue. This is just information. We can check that intra-operatively. We could do a cystoscopy to assess urine efflux from the urethral orifice with or without urethral catheterization, but we may not detect partial transection or thermal injury. Okay. Intraoperative fluoroscopy with urography, that has also been suggested. And universally intraoperative cystoscopy that detects about 97.4% of urethral injury. But a negative cystoscopy does not guarantee that you do not have an injury, because there may be a partial obstruction or injury which is really small. So in this patient, the onset was about correct, 10 to 14 days post-operatively in case of thermal injury, but it was good that we detected it early so that there was no delayed necrosis or partial obstruction of the urethral wall. The presentation was quite classic: fever, flank pain. There was no rise in creatinine levels. Okay, so the blood parameters did not appear as so. And with regards to imaging, it was obvious that there was, we had to look for hydronephrosis, leakage, urethral obstruction, which she didn't have, but she had a bit of a leakage. Okay, you can see that in the picture here. And so, in conclusion, overall, the incidence is low in gynecologic laparoscopy, but the potential morbidity is quite debilitating. Having a patient to go back with a CBD bag can be quite upsetting. And intraoperative evaluation should be undertaken whenever suspicion arises. Unfortunately, sometimes we think that it looks all okay, but with thermal injury, how can we know? It probably comes later, right? So usage of thermal energy is very important here. Careful usage of thermal energy. Prevention of injury can be achieved by careful attention at the location of the ureters all the times. That is, of course, hopefully there are no aberrant vessels and aberrant roots of the ureter because of fibroids or endometriosis. You should always keep a high index of suspicion, as the presentation can be delayed till 14 days with relatively normal pelvic ultrasound or creatinine levels. So that is what I would like to highlight to the young surgeons. And the prophylactic urethral stenting may be helpful in certain selected circumstances, although I cannot recommend it for all. So to remember our morning prayer, to hold my teacher in this art equal to my own parents. Here you can see that the teachers are there, and there are a lot of teachers. A lot of teachers have gone and come over the last 10 years of our practice. And many have, that picture was I think taken in Surabaya or Chongqing. And the bottom picture was taken in Malaysia itself. To consider his family as my own, I must say I miss my brothers and my sisters. Jury, thank you for inviting me. And you see some pictures here, some which would not be recommended for use, but nevertheless, we became sisters and brothers, and I long for the time that we will meet again and do all the nonsense that we do. And to teach them this art, if they want to learn it without fee or indenture. And that is what we do. We learn and we teach. And presenting this case, for me, is a teaching moment, which I hope and want to share with all of you. And to impart precept, oral instruction, and all other instructions to my own sons, the sons of my teachers, and the indentured pupils who have taken the healer's oath, but to nobody else. I wish to thank this girl right here, Arina Hashim, for helping me out with the slides as well and putting it quite nicely. So, till we meet again, one day, hopefully, face to face, and not only resort to virtual hugs and to virtual kisses. Thank you very much, everyone. Kap kun ka. Okay, I'm done. So, will there be any,
Yes, I'm here.
yeah.
Yes, I'm here. Okay.
I'm here too.
I'm here too. A very nice speech and
Why are you laughing?
very
Why are you laughing?
a very nice speech and very good teachings lectures and I don't know, but since January, my fellows encountered 4 cases of the ureteric injuries. Yeah, and 3 from the past fellows and 1 from and 1 is during our training right now, and all of it is are due to the cauterization.
Yeah.
So I think skeletal knife should still be the best, and that's good dissections, traction, like what you have taught. I think it is still the best way to prevent the injuries. Yeah, and but right now in my hospitals, our urologists right now they can put the ureteroscope and then they inject the retrograde cystography through the bladder, and then if they see the tract, they will put a stent through the tract of the dye going up to the ureter. So by doing the reanastomosis that we have learned in Changkeng, the urologists right now they may just put a double J stent, after the injury, because sometimes right now the urologists I think they find it difficult after our surgeries through the cauterization. They find it very difficult to repair. So right now what they do right now is to support the kidney first. So they put the double J stents through the stent. No need to open up the laparotomy. Yes, and after for about 1 month they will check if the ureter is intact because of the fibrosis, then they will just off the DJ stent after 3 months. Of all 4 cases, 1 is remission after the stent, 3 has to do neocystostomy.
I
That's
think
right. Yes.
the issue is also
And I think in my hospitals, this is the first year that we got so many cases. Usually we have none. I think it's because of the COVID.
okay. Willie, how do you explain? How do you explain that it is?
Okay, what's your opinion, Aizura?
How do you explain that it is due to the COVID? But because this has also over the last 11 years of my life. Can you hear me? Can you hear me?
Aizura, you should turn on the microphone.
It's on. It's on. Can you hear me? Can you hear me?
I can hear you. Personally, I can hear you. I don't know what happened with them.
I can hear. Can you hear me?
Okay, great. Yes. Can you comment again? Yes.
Okay. Now, I was saying that personally, I also wondered whether this has anything to do with COVID, late presentation to the hospital, urinary tract infection, conditions are getting worse because it has never happened to us before. And we are very, we are also very worried and scared whenever we deal with that area. So I'm just wondering why. Now, you have mentioned that you have 4 cases. That's a lot. And I don't, I cannot imagine having to deal with that and having to treat that as well. And it helps if the how to do retrograde stenting, because if not, they will have to open up and do implantation, which is even more morbid. But how can I explain that COVID causes ureteric injury?
No,
Actually, me
I was
too.
just joking. Yes.
But actually, me too, because I never do that. I never did the ureter injury by laparoscopy before, but I just did last year in the COVID era as well.
Really? So, so you wonder why? Is it because patients are presenting later to us? Because they don't want to come to the hospital. Because you see, like this patient, she did have a urinary tract infection. Could it be that that little thermal injury, if she didn't have an infection, would have healed up? I don't know. I don't know. That's why I'm opening up to the floor for discussion. And this is a bare all presentation. I'm not embarrassed to discuss the thing, because if it happens to me, it can happen to anyone else. And I think we should discuss openly about it.
Do you think, Aizura, the other grasper you grasp below the uterine artery may cause this injury, crashing beside the uterine artery? The other grasper, I mean. Get my point?
Probably.
When you hold with the other grasper below uterine artery, this may cause crashing injury. I don't know. Or maybe your assistant does not push that much upwards. Because sometimes during watching, I lost the delineation of the cup. So why there is no such push from inside? So you can, that's what I noticed.
Yeah, right. So when the uterus is not really pushed kefalat,
Yes.
then there is no lateralization of the ureter, right?
And the other thing, the other grasper you use is traumatic, I feel. I feel that it was traumatic. So you grasp below the uterine artery. So this may cause also crashing to the ureter. I don't know. That's what I thought.
Yeah.
Okay, I got an idea. Actually, I think we know that. Okay, in the very difficult cases, we will skeletonize all the ureter, and we will skeletonize the uterine artery, and like let everything like so clear, and we can coagulate it. But I think many of the cases that we got the ureteric injury, it's because we thought that case is too easy, like quite easy.
Exactly.
Like look fine and nice and clean, and like because okay, some of the professors said that okay, before we can do anything, we should skeletonize the ureter, like make it like more obvious, and like make the uterine artery like in the single vessel, something like that, and we can skeletonize and we can coagulate it or suture it. But if we do that in every cases, it may take a bit longer time of the operating time. So that means we will do the injury because we think it's too clear. So we will coagulate it like just beside the uterus, and that may cause the injury because we didn't clean it well. So I think, okay, maybe as your opinion, if we really consider and really scared of that, should we skeletonize everything clean in every cases, or we just still select the case that we will skeletonize the ureter? Okay, some professor said, you just clear the ureter and then everything will be fine. And even some professors said, we want to clear the uterine artery, so just clean the uterine artery, no need to clean the ureter, and everything will be fine. Or some say that both. So what is your opinion?
I feel that if I were to ask all my trainees to skeletonize the ureters, it will cause even more bleeding, particularly if it is a straightforward case, because they will be digging and digging and digging to look for the ureters. And I think, I don't know, at least I know in Malaysia, that is also what happens. So,
Even though if you want to skeletonize the ureter at the site of the cardinal ligament, it's really difficult. Usually it's like doing a radical hysterectomy. So that's what I believe. You can skeletonize the ureter beside the IP towards the cardinal ligament. But at that point, it's like doing a radical hysterectomy. So I believe at this site, skeletonizing the ureter, it's just like conducting a radical hysterectomy. That's what I believe. Especially at the site of injury, when it passes beside the cardinal ligament. You
And,
get my
yeah. I don't know. Abi, have you got something to say? You do all the messy, fancy, schmancy dissections, right?
That was congratulations. That was a very good presentation, and I think it's very important to learn from the mistakes. And the beauty of laparoscopy is that we can share the injuries that occur and how to prevent them, especially when you work in a teaching setting such as yourself. So that is, of course, going to have a fair share of complications to share and learn from. So I find personally, when we, at least for endometriosis, we dissect from the normal area to the disease. So when you start going into the disease, that's where the ureter is more fibrotic. And then you have to kind of do a little sharp dissection around the ureter, which you can use either an energy device that you're comfortable with, but also make sure you don't have a thermal injury to the ureter. And also, or you can use cold scissors to be safer. But then if you use cold scissors, you have bleeding. And then if you have bleeding, you lose your anatomy. So that trade-off becomes more difficult there. So like Allah also said, once you enter the retroligamentary portion where the ureter is not disappearing into the parametrium in the cardinal ligament, is where it becomes a little tougher. And that is where you're likely to hit either the uterine artery above or one of the uterine veins below, and the ureter passes through that like a fork. So that is a very difficult dissection to do. But I think with the Kiefer traction in the case of a hysterectomy, one can avoid doing the ureterolysis in normal anatomy. But if there is disease like endometriosis, then I would recommend doing the ureterolysis.
Thank you, Abi. I think that's very wise.
Thanks.
Okay, there's still another questions from the floor from the Dr. Andy asking Aizura about the cystoscopy. Should you recommend to do cystoscopy in every TLH, especially the difficult one? Actually, we do it in Changkeng, I think.
In Changkeng, we used to do cystoscopy routinely. In my setup, I think I have to get my nurses to bring out the cystoscopy machine every time I want to do a TLH. Is going to be a bit of a trouble, but I don't know, it may be a good idea. But again, if it is a small injury, you won't be able to detect that there's any injury. You'll still see urine flowing. You cannot detect thermal injury, not of a very small kind. I believe in this case, it wasn't a transected ureter. If it was transected, you wouldn't put in a retrograde JJ stand. I think it was an injury on the ureter, a nick. How big is the nick, I wouldn't know. But after 12 days, the urinoma was still quite small. So, you know, if I were to do a cystoscopy, I would still see urine flowing, I think. What is your opinion?
Actually, for me, we only do when we're suspicious of the ureteric injuries. That's all. We don't do it routinely, but in my setting, we got our own cystoscopy, so we are all ready for that. But like what you said, it will not give us the true answers every time. So just do it for your good night, good sleep.
So actually the light ureteric stent is good and convenient and like very helpful, right? Do you think?
Will you stand every endometriotic TLH, you reckon, in the future? Should we stand? Would you do that?
We in our center we do it before and after the so we draw after the surgeries in difficult cases or in new cases, new technique. Yeah. So we place stand by ourselves in our center. Yeah, and we will do it just for the sake of teaching, and sometimes new technique development and difficult cases. Yeah, that's all. Yes, for the stent placement. And then we draw out after the surgery.
So you routinely do that?
No. Just for three purposes: for the new development technique, for teaching, and for the difficult cases.
How would you know that a case is difficult until you go in and see it? So you're prepared to stand intraoperatively?
No, oh yes, correct.
Okay.
All right, okay.
Last question, Aizura. How you passed this traumatic event? Was it difficult for you, or you were confident while you were talking to the patient? How you approach this thing in your practice, about your confidence later on by doing TLH? I know you are an expert doctor, but for us, we are just started three years of practice. I was thinking
it was a very
limitation for me to complete performing surgeries. You get my point. So this will make me hesitant maybe later on in doing surgery. So how you pass this?
If you let me talk, Alex.
Okay.
Well, I must say that this is my first ureteric injury over the last 10 years. And it was, of course, very demoralizing. I think waiting for the results and such, I was appetiteless, and there was I felt bad, I felt horrible, of course, I felt lousy. But then again, there were many seniors who were very comforting. There's a Chinese proverb that says, if you go to the jungle often enough, you will meet the tiger. So I suppose statistics do catch up with you. If you've done enough, I mean, maybe you'll come across one, I hope one for the rest of my life. But if you become a statistics, meaning that every year you have one, then you need to audit and look at something, with your technique and your style. But if it is a one-off thing, I suppose my message to the younger surgeons will be scared, be very afraid, be very scared and very afraid and very cautious. Yes. Don't take upon, like what Prof. Lee said, don't bite off more than you can chew, stay safe. But as you progress and you become a bit braver and a bit more brave and a bit more and a bit more, and you think that pardon my French, but your balls start growing, and there might be a little ego involved in this, and you feel a bit more comfortable, boom, humility takes you down again and again and again. And I think that's from the birth, to keep you humble and to keep you steady all the time. But in dealing with the patient, it's just honesty. I do not know any doctors who purposely want to sabotage a patient, right? So you go in feeling that way, and the patient knows that you are also feeling that way, then they realize that you've tried your best. And you've tried your best and your very best, and you're not hiding anything away. So what else can I say? So that's what I went through. And Allah, if you do enough, probably in the next few years you might be giving me a call and say that, oh man, we had this talk back in 2021. So yeah.
Okay, thank you so much.
Yeah. Okay, we run out of the
Great speech.
Yeah.
See you next time. Thank you so much. Next. Thank you.
All right.
Bye-bye, friends.
We'll meet again. Bye-bye.
See you.